Very happy to introduce our next speaker, Dr. Andy Dalovisio. If any of you have had a leukemic patient present in the emergency room in the middle of the night, you've probably called Dr. Dalovisio at some point to talk about what to do. He's an exceptional and renowned hematologist. He trained at Rush in Chicago, a phenomenal program. And he practiced with me at Ochsner for a number of years. He and his family are kind of Ochsner royalty. His dad's been there for as long as I think just about anybody can remember. And his sister's been there for a long time too, I think longer than me. And he moved a couple of years ago to Mary Bird Perkins, where he's building great things out there. He and his family are also huge Tulane fans, so yeah, check that off, check that box off for sure. Tulane alum as well. And he's here to talk about CAR T therapy. So without further ado, I'll have Andy come up.
All right, we're all set. Thanks for the introduction, Mark. And first, I want to thank CAGLA, Chad. CAGLA is a great organization, really advocating for patients and even providers in the state of Louisiana, so a very important organization. Thanks for the talk about burnout. I think it's important. I think we need a whoop ban for parenting. But no, great talks so far. So today I'm going to give kind of a brief talk that I've titled No Patient Left Behind, Improving Access to Cellular Therapy for Patients in Louisiana with Heme Malignancies. And I think what I'm hoping for is it's a short talk, but I hope it's kind of a call to arms for all of us, health systems, community cancer centers, pharma, insurers, to really come together to understand the incoming need for these treatments. And so hopefully you can come away with some potential marching orders for you and your organizations. So I always find this map to be incredibly sobering. Obviously, this is a meeting about cancer in Louisiana. And so if you actually look at CDC data about incidence of cancer in the United States and outcomes with cancer, Louisiana remains kind of at the bottom of the barrel. Top 10 incidents, top 10 worst outcomes, and then you kind of hone in even closer to the river parishes where a lot of us call home, and what you're seeing is some of the highest incidence of cancer in the United States. And unfortunately, we've gotten a lot of press in CBS, 60 Minutes, about this, and there's very factors why this happens, but I think it just points to the fact that advocating for our patients is incredibly important in the state of Louisiana. Included in these numbers are the blood cancers that we treat CAR T therapy with. So very close to home for us. And then I can tell you, having practiced here, the amount of this cancer that we see in the state and in young patients is really breathtaking. When we talk about CAR T therapy, we know that this has been traditionally limited to large urban areas, academic medical centers, FACT-accredited centers, where these initial clinical trials first took place. If you look at the first CAR T approval that came in 2017, really it was limited to a small amount of cities. Over the subsequent 5 years, it did expand to a number of other cities. But now we're really at a point now where we need to start thinking about expanding this to smaller community centers, smaller community hospitals. And the reason being is that we know that only about 1 in 5 patients who meet the indication for this even receive a referral. And so these aren't drugs that are just, we can buy them a few months. These are potentially curative treatments. And so really it's important that we get this 20% up, moving forward. A couple other factors that make the accessibility to CAR T therapy incredibly important for the state of Louisiana is we have an aging population. There's a number of factors here that play into this, but if you look at from 1980 to 2020, the number of patients over the age of 65 has increased by almost 5%. And we also know that the incidence of lymphoma and multiple myeloma increases as we age, and these are the two leading indications for CAR T therapy. So as you can tell, from a simple demographic perspective, the need for these therapies is only going to increase. Another important part about this with CAR T is if you look at the indications that CAR T are going to be for. Right now we have indications for a number of different leukemias, lymphomas, and multiple myeloma. But right now there are dozens of trials. I think I counted over 80 on clinicaltrials.gov looking at CAR T therapy in solid tumor malignancies. There's some early trials showing some success in those spaces. I still think there's a lot of work to go, but I think we'd be foolish to think that these are not going to be coming down the pike pretty quickly and even become standard of care. Additionally, in autoimmune diseases, we've seen some very impressive trials in diseases like multiple sclerosis, lupus, particularly very tough to treat refractory cases. And so we know that these lymphoma CAR Ts that have been repurposed for autoimmune diseases also are likely to be approved in the coming years. So the number of indications is going to improve. Currently, these CAR T programs, or CAR T products, are only indicated for relapsed disease, so your lymphoma or your myeloma that's come back. But currently, there's a number of first-line trials ongoing. We've already gotten some early readouts from these trials that look to be positive in the first-line setting. And so I would expect in the coming years, probably in the next 5 years, we're going to start getting first-line indications for CAR T therapy. So this is going to be standard of care for first-line treatment. So take all these factors together: an aging population, higher cancer incidence in the state, more approvals in earlier lines of therapy, new approvals in solid tumors and autoimmune diseases, and frankly, an inadequate number of centers offering cellular therapy. We're looking at a big, big problem. And this is not 10, 20 years down the road. This is probably in the next 5 years that we're going to see this massive tidal wave of need. So how do we fix it? So I think there's a few topics I wanted to touch on. One is removing regulatory hurdles. Second is reducing payer friction. And then third is increasing the number of centers and practices offering cellular therapy. And this comes down to kind of, I think, two big factors, which is identifying and hiring cell therapy physician and administrative champions, and then also building outpatient delivery models that make these drugs more accessible. So with regard to removing regulatory hurdles, I'd like to give a big kind of prop to pharma, because traditionally, CAR T had been limited to FACT-accredited centers that had run the initial clinical trials. I think the companies came to understand that if they stuck to this model, that not only would their businesses not grow, but also patients that desperately needed these therapies would not get them. So what they've done is actually granted what's called authorized treatment center a designation, so you don't need FACT accreditation. Now, this still requires rigorous confirmation of infrastructure and expertise to safely administer these therapies. And as somebody that's just been through this, it is not a kind of a just sign off and go process. Like, you do have to prove a lot of things that you can do this safely. And I found the environment to be highly supportive and collaborative. It was not adversarial at all with the companies, and it didn't cost anything. And we stood up our program in about 11 months. So it took us less than a year and freezed our first patient last week. So you can do this. The FACT, I think traditionally, FACT accreditation, which is a foundation of the accreditation for cellular therapy, this is our kind of governing body that grants kind of the stamp of approval. They also came to realize that they could not limit this to just large academic centers. So they actually created a standalone accreditation for just CAR T, so you didn't have to apply for autologous transplant or allogeneic transplant confirmation. And this removed a lot of the unneeded burden for centers not pursuing stem cell transplant, i.e. you didn't have to have an HLA lab, you didn't need to have stem cell mobilization, collection, storage that you typically have to have for like autologous or allogeneic transplants. This still requires fees, and it does have stringent documentation and staffing requirements. They actually released the standards for this just in the last year. This is actually free online. So you can take a look at this to see kind of what checkboxes you would have to make at your center if you wanted to take on these projects. They actually do have consulting services. They're an arm of FACT, as well as other private companies that will offer you consulting services. It's not cheap, but they can certainly hold your hand through this process. So kind of getting to the crux of all this, and I think what causes a lot of the obstruction here is the cost of CAR T. So we're looking at probably about, on average, $500,000 for a CAR T product. Now, the majority of this comes from the actual product itself, but all the supportive care that required to do CAR T, apheresis, lymphodepletion, the facility fees, toxicity management, monitoring, you can see the breakdown here. Now, the three kind of models that have been used traditionally for administering CAR T have been strictly inpatient, a hybrid model where patients are admitted maybe just during the high-risk period, or a fully outpatient model. And you can see here, based on the cost, that clearly the cost benefit is with outpatient models, or as much as outpatient as you can keep these patients. So given that cost, we've seen a lot of insurance kind of push back in the state of Louisiana. Now, the American Society for Transplant and Cellular Therapy, they published a paper back in 2023 that took a number of metrics to say what's a state that's friendly for CAR T administration based on their insurance coverage. And we got a wonderful unreasonable rating. So there's a number of factors that play into that. My former colleague, Clark Alsfeld, who's a transplanter at Ochsner, he has done a tremendous amount of work both at the federal level, going to the Capitol Hill, meeting with our senators and state House representatives, as well as on the state level to get Medicaid coverage for this. And they actually got a bill passed in 2023, House Bill 435, that dictated Louisiana Medicaid had to pay or cover CAR-T. But then the asterisk came. So what Louisiana Medicaid said was, well, okay, we'll reimburse this, but they posted rates that basically made it untenable for any kind of health systems to offer coverage for this. And so if you look at whether it was the acquisition of the product, the hospitalization, complication management, the apheresis, the post-infusion monitoring, essentially it was either a wash or a loss when they got Medicaid reimbursement. So even now, if you were to offer a Medicaid transplant, the estimated loss would be between $200,000 and $400,000 for a health system. Not really tenable in today's environment, right? So I think there's a lot that needs to be done on that end, and I think that needs to come from health systems, physicians, patient advocacy groups about getting better coverage for CAR-T therapy for our patients, because we know a lot of patients have Medicaid, and as Medicaid's getting squeezed more and more, as you see in the news, I think this is only going to become more important. So not to say that commercial insurance is the easiest to deal with either. Particularly in the adoption of community centers, which is what we want to do, expand these therapies to community centers and meet people where they are. There's still a lot of financial barriers. We see high upfront CAR-T acquisition cost, bundled payment negotiations favor large health systems. Large hospitals capture inpatient and outpatient revenue. Community programs are often excluded from preferred payment models. With regard to contracting barriers, centers of excellence favor large academic hospitals, existing system-wide payer contracts, and long credentialing timelines for new CAR-T programs. And then we have limited payer familiarity with community programs. I can tell you, having started to deal with this, we really have to kind of battle for every single case agreement. It takes multiple red lines, and a lot of times this is when patients with aggressive cancers are waiting to get the all go ahead for this. So this can really be anxiety-provoking for the patient, the physician. And then you can do all this work, say a patient's eligible, and then the insurance can turn around and say, well, we're going to cover the X, Y, Z on this amount, and actually operate at a loss. So we really need to figure this out, especially insurance companies and health systems, about how we can make this tenable for everyone. There's also a lot of perception barriers, I think, with community cancer centers. Assumption of toxicity management requires academic centers. I think this is not necessarily true. Perceived infrastructure advantages, travel programs that steer patients to contracted sites, and then community outcomes often are under-recognized. So basically what we get from all these things is an impact on access to states like Louisiana. So ways to help this. So one, I would say, a main thing people need to do is, or programs or systems need to do, is identify a physician championship for cell therapy. So you have to have a clinical leader. You have to have a cheerleader, somebody that's going to come in there and kind of, like I said, knock heads, beat on the table, get things done. So you want to identify that CAR-T clinical lead. They need protected time. The adjustment of SOPs, meetings. It's a very time-consuming process that has to be taken outside of direct patient care. So that needs to be recognized. And then it needs to be a physician-known program. It can help build a referral base, educating regional oncologists. It can promote early CAR-T referral, which we know is imperative to good outcomes, and then provider outreach. And then as a program driver, it helps develop program protocols, coordinate care, and guide FACT accreditation. So I would say it's the single most important factor in successfully launching a community cellular therapy program. I would tell all my colleagues at either centers that are starting or thinking about this, start identifying a person now. These programs are essentially at every major academic center now where our fellows are coming from. And so really every fellow you're going to get now is going to have some experience. And so if you're hiring new doctors, start focusing on fellows that are interested in this or willing to take this on, because it's going to be important. And I do think that CAR-T therapy is going to be the standard of care in coming years and may be necessary for your survival as a practice financially. If you can't offer a standard of care, people are going to go elsewhere. So important to start thinking about this now. So another thing that we've really focused on at Mary Bird, and the experience has been, is really administering in the outpatient setting. So planning to only admit patients when they need to, rather than the traditional kind of 10 to 14-day admission. We know that outpatient CAR-T therapy means increased access. It's increased treatment capacity. It reduces the dependence on limited inpatient oncology beds. It allows more patients to be treated simultaneously. This enables treatment at community cancer centers. It can be delivered in an ambulatory setting, avoids referrals to distant academic hospitals, i.e. meeting the patients where they are. It reduces patient travel burden so they can be closer to their home and their loved ones. And again, this is particularly important for rural and underserved regions. It also shortens times to therapy, avoids inpatient bed delays that postpone infusion, and we get faster transition from apheresis to lymphodepletion to infusion. And it also lowers the cost, as I showed earlier, sometimes substantially by up to half. This avoids high inpatient episode costs, and it makes CAR-T more financially viable for community cancer programs. So a little bit about our experience. I came on back in January. In about a year, it took us to kind of get activated for CAR-T. Again, I think they did a wonderful job of identifying a physician champion. I would recommend that you contact pharma companies early. They are wonderful partners in this, and they want you to succeed very much. So one of the first things I did was send emails out immediately to pharma saying, hey, let's start talking, let's get this conversation going. And really, they have a ton of resources to help get this off the ground, and they are very interested in helping community sites. You want to identify a partner hospital. I know for smaller community cancer centers that are mainly outpatient, you do need to identify a partner hospital. Look, as much as we try to keep these patients out of the hospital, we know about half of CAR-T patients will get admitted during their initial 14 days, but that means half won't. But again, you want to be able to identify a hospital that has adequate ICU care, specialist coverage, neurology, cardiology, infectious disease, GI. Again, most large community cancer centers will have this. And I did make a point to kind of reach out to those subspecialists right when I came on saying, hey, we're going to need a champion in each of these subspecialists to kind of help us should a patient get admitted. And I found people to be more than interested. And frankly, a lot of the younger kind of subspecialists who are coming out of these academic centers have experience dealing with these complications in their own fellowship. So it's not like they were like, what is this? We don't know. You do need to identify an apheresis partner. Kind of large health systems have typically have in-house apheresis. But right now, companies like Fresenius, Red Cross, they can offer these, and you can contract with them, and they can actually even come to your site, collect these cells, and ship them off. And so these actually are in place, and they often have their own SOPs and things like that that really make it easy. You want to get practice, leadership, and legal and financial teams started on contracts early. Because of the cost of these, there's tons of back and forth and redlining. And so you really want to have somebody that's experienced from the legal and financial side of negotiating these contracts. And again, start building your team early. You'll need APPs, pharmacists, nurse coordinators, quality program directors, financial counselors, benefits managers, and you need to be patient. This process can take a year, even longer. But again, if you're dedicated and start putting these feelers out, it's definitely something you can achieve. I would say focusing on outpatient administration is really important. One easy way to start this process is to start with bispecific antibody outpatient administration. It's a great way to get your feet wet before rolling into CAR-T. We've adopted an outpatient-only ramp-up program at Mary Bird. So with myeloma bites, there's actually a lot of evidence now. They've had large group studies out of Mayo, Emory, showing that this can be safely done with minimal admission risk to patients. Obviously we like to see patients with a reasonable disease burden, acceptable comorbidities, compliance, and a caretaker before we can kind of sign off on outpatient administration. We have routinely started giving prophylactic tocilizumab as a standard pre-medication 30 minutes before step-up dose 1. And what we found is that has decreased the CRS rates from over 70% to less than 10%. And in some small studies with certain bispecific agents, 0% CRS. And so I think that really this is the wave of the future to keep patients out. One of the things that I often hear is, well, I'm not going to get reimbursed for my tocilizumab. I would tell you to look for biosimilars. Some of the biosimilar TOCI agents now are actually very cheap, and it's much cheaper even just cover the cost of that. We've even had some luck getting reimbursed. So that's something you want to look into. And actually, it's included in NCCN guidelines now. So we've heard a couple saying, well, this is off-label. It's in NCCN now. They use the word consider, which is always tricky, but that's in there. Again, we have evidence-based protocols you can quote now. We provide home monitoring kits to patients. So basically a blood pressure cuff, a pulse oximeter, a thermometer, that they take their vitals twice a day. We educate the caretakers and the patients to notify us immediately if anything develops that's of concern. We provide a patient what we call our pocket deck, so a 10 milligram dexamethasone dose that they can take at home. with instructions to kind of recheck their vitals immediately after, and obviously they worsen, they come on into the ER. And then we do MD APP visits the day of injections, and then nurse phone visits with modified phone ICE scores, basic CRS, ICANN screener questions, and that gets escalated to the MD if it's abnormal. And we have clear escalation pathways for presentation to the emergency room with our partner hospital and for admission to the floor of the ICU. With regard to the lymphoma bites, we see a lot less CRS than we do with the myeloma bites, and so we still do the same thing of the same day appointment, and then telehealth visits as with the myeloma bites. Again, generally a lower CRS rate and severity than with myeloma bites. We prefer epcoritamab given the CRS rates versus GlowFit, and then we follow standard pre-medications prior to the dose 1. And we don't use prophylactic tozli unless they're deemed high risk by the provider, so elderly, high disease burden, or comorbidities. With regard to our CAR T program, before we even tell a patient they can do this outpatient, we have criteria that they must meet. So we actually use the modified E6 score, which is a combination of some laboratory tests we punch in, and it gives you a risk for the patients. If they're low to intermediate, we say that they're eligible for outpatient. They have to have an acceptable comorbidity profile, acceptable caretaker support and compliance, acceptable disease burden, and then the weekend clinics. So they do Monday through Friday clinics, and then on weekends we have an APP-MD covered clinic on the weekends. Same home monitoring vital kits that we provide with our bispecifics, and then day 0 to 10 or to day 10 to 14, depending on kind of how the patient's doing. We do Q4 to 6 vitals while awake at home. And then temperature, and then three times a day vitals, and then we do a twice ICE score home. They do a daily visit in the morning, and then we do a APP phone visit in the afternoon, and then we have clear escalation pathways for presentation to the ER and rapid tocilizumab or steroid administration. So a little bit about the E6 score. I found this to be very helpful. This is a simple tool that's been validated. So you take a patient's LDH times a creatinine divided by platelets. And this is calculated between day 5 and 0. And based off of their number, you're able to get a prediction of grade 3. Grade 3 or higher CRS. And so for our kind of high or very high patients, we've actually have a plan in place to where we may prophylactically admit those patients, following administration of their cells. So take-home points, the oncology community in Louisiana has an obligation to our patients to make these treatments available close to home. They need these therapies, the need for these therapies is only going to increase. We need to start investing in personnel and infrastructure now, and cell therapy will likely become the standard of care in many disease states in the post-chemotherapy world. And it may be a matter of financial viability for community oncology practices to adopt this. And we now have evidence that based practices to safely administer these treatments in the outpatient setting. And next-generation cellular therapies, risk prediction tools, and prophylactic interventions will make administering these in the community easier, I truly believe. Thank you. Any questions? Thank you. All right.